Hello, welcome to activity number 7, clinical trial, in which we're going to review this interesting article called Capsid Inhibition with lenacapavir in multi-drug-resistant HIV-1 infection. In the background, we have that for most patients with human immunodeficiency virus type 1 or HIV-1, an effective antiretroviral regime can be designed. However, some patients have multiple treatment failures due to viral resistance or unacceptable medication side effects. And this is where lenacapavir appears, because it's a first-in-class long-acting fashion inhibitor of HIV-1 capsid function that have shown antiviral activity against viral mutations that are resistant to major antiretroviral classes of drugs in a phase 1b study. And this is exactly where we are concerned now, as an ongoing phase 3 Capella trial is evaluating the efficacy and safety of lenacapavir in patients with multi-drug resistant HIV-1 infection. And then we have our hypothesis, that is that in patients with multi-drug resistant HIV-1 infection, those receiving lenacapavir will have a lower viral load than those receiving a placebo at the end of the study.
The objective is to evaluate the antiviral activity of lenacapavir administered as an add-on to a failed regimen and to assess the efficacy and safety of this drug in patients with HIV-1 infection resistant to multiple drugs.
Hi, so I will talk you about the type of the design. So this is a randomized and placebo-controlled multi-center study of GS6207 in TLWH. So we have this type of the design for the article capsid inhibition with lenacapavir in multi-drug resistant HIV-1 infection. For randomization, we have the participants will assign it into a screening number using the interactive web response system on the day of the screening visit. So we will separate for cohorts. So we have the cohort 1 and cohort 2. Well, the methodological strategy were that the patients with multi-drug resistance of H1B infection were enrolled in this phase 3 trial in 2 cohorts, as I already said before. And so according to the change in plasma, HIV-1 RNA level between screening visits and cohort sections. So as I already told you, we have the cohort 1 and cohort 2. So where the cohort 1, the patients were first randomized in a 2:1 ratio to receive oral lenacapavir or placebo in addition to their failure of therapy for 14 days. And then during the maintenance period, starting on the 5th day, patients with lenacapavir group received subcutaneous lenacapavir once every 6 months. And those in the placebo group received oral lenacapavir. So it's followed by lenacapavir subcutaneous. Both groups also received optimized background therapy. In difference, in the cohort 2, all the patients received open-label oral lenacapavir with optimized backbone therapy on days 1 through 14. So subcutaneous lenacapavir was in these administrations once every 6 months, starting on day 15. So the primary endpoint was the percentage of the patients in cohort 1 who had a decrease of at least 0.5 long copies per millimeter in viral load at day 15. A key secondary endpoint was a viral load that less at 15 copies per millimeter at week 26. So the sample size, we have a really small size. We have a total sample size of 36 participants for cohort 1A and cohort 1B. And then for the outcome and discussion, we have all these specific points. That is that lenacapavir led a significant decrease in viral load as a functional monotherapy. So that's one of the most important. And the second one, in the combination with optimized background therapy treatment with lenacapavir, also led a high rate of virological suppression along with a clinically meaningful increase in the CD4 count of lymphocytes, and then reduction in HIV-1 RNA levels. RNA levels are medians for 16 to 24 weeks have been associated with a reduced risk of disease progression and death. So that's one of the very, very important points of this trial. And efficacy across the subgroups that were defined according to the optimized background therapy suggests that lenacapavir contributed to the treatment efficacy across a diverse in a difficult to treat population. So limitation of this trial, it includes that is a small sample size, as I already told you, and it has a limited follow-up. But however, the new treatment options for patients with multi-drug resistance for HIV infection are needed, and long-term data are being evaluated in this ongoing trial.
And talking about study subjects, a total of 72 patients were enrolled with 36 in each cohort. In cohort 1, the sample size was 36 patients who were randomized in a 2-to-1 ratio to receive oral lenacapavir or placebo, in addition to their failed therapy for 14 days. And in cohort 2, all patients received open-label oral lenacapavir, followed by subcutaneous lenacapavir with optimized background therapy on day 1, and began receiving subcutaneous lenacapavir once every 6 months on day 15. Some points of inclusion criteria of study subjects are willing and able to provide written informed consent, participants 18 years of age, and assent participants 12 and less 18 years of age prior to performing study procedures. For participants 12 and less 18 years of age, present or legal guardian willing and able to provide written informed consent prior to performing study procedures as required by local law. Adult age greater or equal 18 years of adolescent age greater or equal 12 and weighing greater or equal 35 kilograms. 3 are receiving a stable failing ARV regimen for more than 8 weeks before screening and willing to continue the regimen. 4 have HIV-1 RNA 400 copies at screening. And 5 have a screening or available historical HIV resistance report showing resistance to greater or equal to antiretroviral medication from each of greater or equal 3 of the 4 main classes of antiretroviral medications. And about exclusion criteria, some points are, number 1, an opportunistic illness requiring acute therapy within the 30 days prior to screening. 2, active serious infections other than HIV-1 infection requiring parenteral antibiotic or antifungal therapy within 30 days before screening. 3, active tuberculosis infection. 4, acute hepatitis within 30 days prior to screening visit. Number 5, untreated or newly treated hepatitis B virus infection.
Results and evaluation of the results. Of the 36 patients you enrolled on cohort 1, the 24 who received lenacapavir had a low LHIV NAU value compared to in-ground control group. Most patients had severe immunodeficiency at 74% with a CD4 count of 4 to 200 cells per. The median was higher in the lenacapavir group than in the case of group, 172 cells versus 85 cells per cubic millimeter. Therefore, the third patient had more advanced HIV-1 infections. No lenacapavir related serious advance found in the phase